what I want to do is, rather than go into all the sort of hairy detail about all of the details of the research, et cetera, is just to talk to you about where we are with COVID now, what the future might hold, and sort of where things stand at the moment. So we know we've been dealing with this for, frankly, it's been 3 years. The first cases of COVID probably hit the shores of North America in November of 2019, when they did plasma, sort of what was stored in plasma. They found that there were probably a couple people who had it here as early as November of 2019. And we know what's happened since. Lockdowns happened in California in March of 2020, and we've just had craziness ever since. And one of the things I do want to do is just kind of spend a moment to reflect on what you all have gone through over the last 3 years, and particularly to remember, even though it was gnarly, how it was back before we had vaccines, and what sort of everybody went through, how scary it was, the PPE shortages, watching people get so crazy sick with a virus that we honestly really didn't know what to do with, and was doing all kinds of crazy things to people. Like, I don't know, they just got so sick so fast. I want you to give yourself credit for what you did. And you lived part of what we're going to talk about here, as far as preprints and how information got out and how research was done and how it was interpreted, et cetera. But you really did this in real time. And one of the things that happened because of this pandemic, it's once in a 100-year, hopefully, knock on wood, once in a 100-year events, is that we had to learn on the fly. We had to learn from each other. We used a lot of social media initially to figure out what was working and what wasn't, and to kind of figure out how to treat this thing. It was making people so sick, to describe what the findings were, to describe when intubation wasn't working, et cetera, to kind of communicate with each other, which was all well and good, except that it also led to a rash of the public kind of seeing our dirty underwear, the public sort of seeing how science works and evolves, and preprints that were put out before they were peer reviewed because we needed the information, but then sometimes weren't exactly right. Or science is messy. And in fact, you have some really strong faculty there to tell you all about the messy bits of science, which we all know, but are really hard for the public to absorb. So between all the social media things that happened and the preprints that happened, by the way, preprints, when they finally do get peer reviewed, usually get published. They actually are fine. And that's something the panel can talk to you guys about. As far as preprints aren't all terrible, some aren't so great. But the other thing that happens with preprints is that studies were being done on all different parts of the world. And some were done in the pre-vaccine and the post-vaccine era. And some were done with one kind of variant and another kind of variant. And it just led to kind of messy literature that made it really hard for especially the lay public to really understand what was happening. And it also led to, as we know, an incredible amount of politics. Politics got involved in this, and politics has made it a big mess, and disinformation is really real. And frankly, I think even in the room right there with all of you, there are different opinions and attitudes about what works and what doesn't, and whether vaccines are worth it or not. Or I think most people in medicine are on the same page, but I've been lecturing now. I've given over 100 lectures on COVID to medical people out there, and I've been amazed at the range of responses that I get and the kinds of questions that I get. So clearly, even in the medical world, there's a broad range of how people have responded to this thing. So let's sort of see where we are now. So we know that these variants have been evolving, and what we have right now is what's called now being called a variant soup. We had one variant and then another and then another, and now we have basically Omicron family that has all these subvariants out there. And it's kind of good because we're a little bit of a sweet spot in that it's not as deadly as it used to be. And that's a combination of a lot of things. Part of it is some immunity that people are getting from being infected. A lot of it is from vaccines and helping people from getting super sick. So we know that this variant soup is making it a little harder to kind of get our head around how bad it is. Testing isn't happening as much. We don't really have good measurements other than maybe wastewater and some countries that are reporting really well their numbers, but we don't have a great grasp on this. And we do also know that this viral soup that we have is changing how we can treat this for some people, and changing how we actually do vaccinations, et cetera. So it's a bit of a mess. We also know that this virus is not like a cold, and it really, frankly, isn't like the flu. It causes all kinds of things, even in this milder form, that may be long-term problems. We don't know what's coming down the pike for people who've been infected. We do know certain things, and again, in this messy science that we're learning about, a lot of associations, a lot of observations, some randomized controlled trials, some different places in the world, et cetera. But in this messy literature, what we kind of know is that this isn't the flu, And it definitely has some side effects that are a problem, or it increases the predilection for certain things like clotting or heart attacks or strokes or maybe Alzheimer's. Long COVID is a real thing. Myocarditis is a real thing. We know that, right? We've seen it in our practices. We know we don't know what's going to happen long-term to people. And there is some evidence that all of these complications happen even with mild cases. There is some evidence that some things will decrease the risk of these. Vaccination seems to drop the risk some. Some of the treatments we have, particularly the outpatient treatments, may decrease the risk some of these long-term effects. But we know that this isn't the flu. The flu doesn't do that to us. It doesn't give us long-term Alzheimer's, at least, well, not clearly so anyway. So we know that this virus is different, and the variants changing makes it a very challenging thing to do, to not just practice in medicine, but to also talk to other people about and talk to people who aren't in medicine about. We know that the current approach is basically a you're on your own kind of approach, pretty much worldwide. Despite the fact we know mitigation works, things like masks work, and you can read whatever you want in the literature there. There are different sides of this story, but just the fact that we didn't see flu for a year or two, we didn't see it. And in fact, one entire strain of influenza has just vanished from the planet. When we locked things down, we really had people not out and about, and we had people wearing masks. Masking works, and I'm willing to bet that there aren't a lot of masks in that room because it is a yo-yo, you're on your own kind of thing. So mitigation isn't really happening very well. Vaccination is out there, but it has changed. It definitely works. It increases neutralizing antibodies. You can still get infected, that's true, but you're less likely to get infected if you're vaccinated. The bivalent vaccine is out there. We'll talk a little bit about that and what it gives you. The reality is vaccinations and mitigation are useful in helping kind of minimize this, but we've kind of just let this thing run. And right now, the people who are dying, actually, at least in North America, are majority vaccinated. Now, there's a couple, it's not because the vaccine doesn't work. It does. It just means that older people who already have underlying conditions are now, a lot of them are vaccinated. A lot of them are getting infected because it doesn't prevent infection, and they have underlying problems. So there's a lot of increasing death in older people in particular in this country. We're still seeing 400 to 500 cases a day of people dying of COVID. So it's not gone. It's still around, and it still poses some challenges for us, whether we want to kind of think about it or not. It still poses some challenges. So how do we address this? So one of the things I want to talk about briefly is vaccines, because I still get all kinds of questions from people about vaccines. And I get a lot of, should I get it? What's the value of this? It doesn't prevent me from getting infected. Why do I bother, et cetera? And it's really worth remembering. By the way, most emergency physicians, anyway, across North America are vaccinated. As soon as the vaccines were available, we ran out and got them for very good reason, because we were on the front line seeing what was happening with this virus to everybody. So vaccines work, and they work for what they were originally designed to work for. So I want to just tell you, these were not designed to be sterilizing antibody-producing vaccines, which means I can't get infected at all. They were meant to be neutralizing antibody vaccines. And think about it, it makes sense why. We had a brand new virus that was highly lethal, especially in older people. It had the potential for overwhelming the healthcare system. And frankly, in certain areas, it did. Overwhelming the healthcare system if a lot of people got sick at the same time. The goal of that initial vaccine was we just need to keep people out of the healthcare system and keep them from dying so that we don't break the healthcare system, so we don't cause it, pardon me, to break. So its initial design was to prevent hospitalizations and deaths. It was not designed to even prevent symptomatic infection, frankly. And it wasn't designed to cause sterilizing antibodies. It was just, let's get this thing out. We have the technology to do it quickly. How great is that? Let's do this. And it did it in spades. On the original, the sort of wild type variant, it was phenomenally successful, and that has sustained, which is remarkable actually, as far as keeping people who are vaccinated out of the hospital for the most part. Again, as people get older and the variants change, that's changed some, but it still has significant efficacy. Unvaxxed versus vaccinated, you're 8 times more likely to be hospitalized or die if you're unvaccinated. So it still gives you benefit to be vaccinated. So it's been great to keep the healthcare system afloat. It really has kept people out of the hospital. It's been wonderful, but it has led to some changes as the variants have changed. So we know that the original vaccine has lost some efficacy in keeping people from getting infected. Initially, we got a benefit. It also decreased your risk of getting infected from the original virus. As the variants have changed, it hasn't. We know that. We know we can get infected. My household is a coughing, hacking, snorting example of that. that you can still get infected. But again, it does still have the benefit of keeping you out of the hospital. Does this new bivalent vaccine buy us anything? So the new vaccines that are out there have the original wild type, and we know it has BA.5. So there's these new mRNA vaccines that have both in there. What do you get from that? Well, we know you do get a boost in neutralizing antibodies. We know in this variant soup that is out there, you do get a boost as far as being more resistant to infection from some of these variants. And in fact, a couple of the variants that are a little bit alarming as far as what they're doing out there. So that's kind of nice. It decreases your shedding time if you do get infected. It keeps you out of the hospital. It probably decreases your risk of long COVID. But again, this is new data, again, messy data out there. This is new data, but it probably decreases that. So that's helpful. And so these vaccines have been really instrumental, frankly, in keeping our healthcare systems from completely imploding. We know they're imploding already anyway. We already know that there's big issues in healthcare already. Imagine if we were getting as many patients who were infected with COVID as we did even a year ago when Omicron really hit, a little less than a year ago, when Omicron just swamped us with people sick with Omicron. Even though it was less sick, there were more of them. So we still got swamped. It's doing its job. These vaccines are doing its job. So what's the future with vaccines? Like, where are we going to go with this thing? So one of the things I want to mention is nasal vaccine. So one of the concepts here is if I can get all of the sort of the immunity in my nose kind of ramped up. We know that mRNA vaccines don't do that, but these nasal vaccines do. Will that help? Can that prevent this? And I will tell you, we're not doing research in at least the United States on nasal vaccines at the moment. There's no funding from the government on that anymore. So that's not happening, but it is happening around the world. And some of these vaccines are working pretty well, which is pretty exciting. Some of them are complete duds and they're not working at all, but there are a couple across the world that have had some benefit. And we'll see if these actually are a link in the chain. I will tell you one place they're not going to be a link in the chain, though, is for people who can't get attenuated virus vaccines, people on immunosuppressants, people who are transplant patients, for instance. It may not be useful for them, but that is something coming down the line. And will we need a vaccine every year? Oh, who knows? Probably, frankly. We will need an adjustment as these variants change over time. How we do this is going to be complicated for sure. And are we going to get more benefit every time we have a new vaccine? It's not clear. Is this going to be like the flu vaccine where it changes kind of predictably, or we think we can predict it and change it that way? Is it going to be just kind of a pot shot? Is it going to be where we don't get any more benefit as we continue to change this vaccine? We don't know. Again, we don't know, but odds are in continuing boosting, continuing sort of up to date on your vaccine will be something that, by the way, fully vaccinated is a term that's gone. Up to date is sort of what they're using now as far as you've been boosted with what's out there now. So up to date is what they're using now on the vaccine sort of name. So that's sort of where we stand. The other thing to know is, will there be, one of the exciting things is, will there be a universal coronavirus vaccine? And that's kind of exciting. That's possible, by the way. So there are two places in the United States that have gotten a bunch of money on already, so it's out there and being done, on developing a universal coronavirus vaccine. And it's a really cool vaccine if you look at the structure. It looks like a soccer ball. And on each of sort of the faces of this, here in the World Cup, it's perfect to talk about soccer balls. But on the faces of each of those little sort of parts, those little flat parts, is a bit of the virus. And all the coronaviruses. So this is we may actually cure the common cold if this thing works. We know that they're testing this for flu. There is a universal flu vaccine that's being tested right now. It's being moved to primate testing that has all of the hemagglutinin on it, or in it, that we know cause pandemic kind of influenza. And it's worked so far in murine models. Let's see if this thing works in primate models. And we may be able to do that with flu. It's a little more complicated with coronavirus, but that's something that we may be able to do. So kind of exciting. Let's get into treatment. So let's get into treatment recommendations and sort of kind of focus on that for a little while. A couple of things to know, and you may already be aware of these things, but there's a couple of resources I highly recommend, because this thing changes all the time. It really does change all the time. And the NIH has a one-page summary of treatment guidelines for COVID, inpatient and outpatient. All you do is Google NIH COVID treatment guidelines, inpatient, outpatient. The NIH has one. The IDSA, the Infectious Disease Society of America, has one that, by the way, is really well annotated. So is the NIH if you go to the big document. But the one that the IDSA has is very, very well. And they have a wonderful tables for each treatment, and what studies have been done and what they've shown. Really, really nice. But they also have sort of executive summaries. And then the other thing to be aware of is the Health and Human Service in the United States, the Health and Human Services Department. Just Google Health and Human Services COVID treatment locator map. And it's actually a map of the United States where you can put in a zip code or put in a city, and it will tell you where you can pick up something like molnupiravir or Paxlovid, or even some of the like infusion for remdesivir, that sort of thing, where you can get that done, how many doses they even have available. So if you really need to know that, say you're traveling and you'd like to know that, go to that website. So Health and Human Services COVID treatment locator is a map. It's awesome. That'll show you what's where, it'll tell you exactly where to get these kinds of things. Really useful. So NIH treatment guidelines, IDSA treatment guidelines, and the HHS sort of tracker, sort of location tracker. So when it comes to treatments for coronavirus, we've been through all over the map on this stuff. And frankly, we've really boiled down to very few things that really work. We had all kinds of things that were tried in the beginning. And actually, there's the recovery trial, which has all kinds of things in it that are being thrown around all over the place. In this sort of platform kind of trial, very complicated trial, but looks at various things at the same time, which we have to do when we have a brand new thing out there. A couple of things I want to just dispense with that are off the table. Hydroxychloroquine in any shape or form is off the table. Azithromycin is off the table. There are a couple of the antibodies that were before are not useful. I'll talk about that in a minute. Famotidine, not useful. The couple of the antiretrovirals that were used for HIV did not pan out very well. The combos did not pan out very well for coronavirus. They're gone. Colchicine doesn't seem to work. The one thing I want to mention in a little bit of depth is ivermectin, because there are still a lot of people out there taking it. I have neighbors that still take this. The IDSA and the NIH have come up flatly not recommending the use of ivermectin on any level, prophylactically, treatment for an outpatient, treatment for an inpatient. They have said no. But I will tell you, I'm going to read you a quote that's actually in the IDSA, pardon me, IDSA recommendations online. It says, the guideline panel concluded that the undesirable effects outweigh the desirable effects, though uncertainty still exists. And most informed people would choose the suggested course of action, which is don't use it, while a substantial number would not. What they do in this recommendation is they acknowledge the fact that the science is a little bit messy, although I will tell you the literature is pretty clear on ivermectin for the most part. But they're also acknowledging the fact that the science isn't perfect. So there are varying doses, there are varying times to dose, there are varying dosing durations. There are some patients that are treated early, some patients that are treated later. Some are more sick, some are less sick, some are treated in other countries, some are treated with other variants. It's a messy science. None of it has ever really shown any significant benefit, but they sort of put out there that it isn't completely clear. Well, frankly, there's a lot of the things that we have out there, it isn't completely clear because of this kind of messy literature, but they've kind of caved a little bit to the pro-ivermectin crowd. Again, this is one of the questions I still get a lot from the medical community of people who really like to prescribe it, really feel it might do something, and are all in on this. And so this is something that each person has to decide. There is a preponderance of literature that does not show a benefit kind of on any level so far. Is there a possibility that we just need to hit the right combo at the right time, et cetera, et cetera? Maybe. And that's what the IDSA is kind of acknowledging here. So when they say, you know, we can't be 100% sure on this thing, but just be aware of that. So that, I think, to me, frankly, encapsulates a lot of the problem that we've had with things changing so quickly with this coronavirus, what the variant is, where you are, how old, what the population is being studied in. You know, South Africa population is not the same as North America population. So we know that it's just messy data. The data is very heterogeneous, and they acknowledge that, at least when it comes to ivermectin, as far as whether you should be using it or not. But they come down to saying no. I'll tell you, the couple of the more recent randomized controlled trials say absolutely not, it doesn't do anything. But it's a relatively safe drug overall, relatively few side effects. We don't honestly know if you take it for years and years and years what it does to you. But that's just sort of where we stand with ivermectin. Not recommended by NIH or IDSA, not used by most people, but they still leave the door open a little bit. Now, I'll tell you another area of where things have changed is in the use of Evusheld. So Evusheld is basically monoclonal antibodies, a combination of them, that are given to passively immunize people, particularly people who don't mount any antibody response at all to the vaccine and who are immunocompromised and high risk. So this is like transplant patients, for instance, who can't take some of the medicines that we have out there. Evusheld was this magic medicine that was given to these folks that could give them 3 to 6 months of passive immunity. It was pretty fabulous, great. Evusheld for the Omicron variants, though, was less effective and had to double the dose 6 months or so ago. And the current sort of variant soup, it doesn't look like Evusheld works very well. It is still being used by people out there, and it's being recommended by some people basically because what the hell else are people going to do who are transplant patients? And for some of the variants, it might have some efficacy, and we're not sure which variant any individual person is going to get anymore. So some people are still using it, but just know that Evusheld, which really was the magic ticket for immunocompromised people, doesn't seem to work very well. So that's kind of scary. It's taken one of the treatments, or one of at least the prophylactic treatments, to give people a chance to travel and get out and about, kind of off the table. Now, treatments themselves, like the things that we know might work. Glucocorticoids. So a couple of things about glucocorticoids. Inhaled glucocorticoids in general are not recommended unless there's another reason to use it. So if somebody has COPD and you would use it anyway, asthma, you would use it anyway. But if it's just for COVID per se, outpatient kind of treatment or inpatient kind of treatment, it's not recommended. Frankly, it doesn't seem to do much. But systemic glucocorticoids in anybody who is hospitalized, especially ECMO, mechanically ventilated, or oxygen dependent, that's the group that benefits from getting Decadron 6 milligrams a day for 10 days. They cut that, by the way, back to 5 days when somebody's super sick, but for 10 days, that's the recommendation. You can use an equivalent to Decadron if you don't have dexamethasone, that's absolutely fine, but you shouldn't be using it in people who are not sick enough to require oxygen. Now, this comes mainly from the recovery trial, but it seems to be on a risk-benefit ratio, more risk than benefit. The side effects of the steroids don't outweigh the benefit you might get from the steroids. And by the major benefit you get from steroids is decreased mechanical ventilation. That's why you want to give it to oxygen-dependent people who aren't quite so sick yet, to prevent them from getting intubated. That would be nice. So the steroids are definitely on the table as far as treatments are concerned. Glucocorticoids, Decadron, systemically oxygen dependent. That's the way to kind of do that. Some of the antibodies that they use in-house, the IL-6 inhibitors, we rarely use in ER, so I'm not going to spend much time on that, but that is something for the super sick people to consider using. Convalescent plasma was a big thing in the beginning. And in fact, some of you in the room that are listening to this right now or watching this right now who got sick early from COVID, I know quite a few people who wanted to go donate their plasma so it could be used to help somebody else. That actually was an alternative early on, and it has kind of fallen off the map as variants have changed, and we're not sure which variant people have. It's still getting a little bit of interest right now, just if they could maybe pool it to figure out some way to help, particularly the people who are immunocompromised and don't have a lot of options for treatment. But it is really not recommended anymore to be used. It's something, though, and there's an update that just came out a couple of days ago. It says don't use it, but they're going to look into maybe there's ways to sort of combine this to make it something that might be useful, particularly to people who get severely ill who are immunocompromised. Remdesivir is the other thing, sort of an inpatient treatment group. I will tell you, the data on remdesivir is not fabulous. In fact, it's kind of messy data on how it was all released in the beginning. And it's kind of, if you want to look in your manual, there's a wonderful sort of history of how remdesivir information was kind of dispensed and kind of the mess that happened with that. But the reality is remdesivir probably has some effect, mild to moderate, particularly people you don't want to progress in their symptoms. You can use that both as an inpatient and an outpatient. Now, that's important because it is one of the 4 things we can use as an outpatient treatment for people. And I'll get into that in a little more detail because I'm going to go through the 4 treatments in detail. But remdesivir inpatient, certainly if somebody's sick and you're admitting them. Outpatient, it's one of the alternatives that we have. So when it comes to outpatient treatment for COVID, for people who get infected with COVID, I'm going to start with Paxlovid. So Paxlovid we know is a combo drug, and I can't pronounce the first one. The other one is ritonavir. I can't pronounce these things anyway. It's one of the virs that is combined. I could, but I'm not very good at that, pronouncing it. Anyway, who gets this? I want you to know it was studied in unvaccinated, symptomatic, high risk, particularly older people, was what the initial studies were done. That's the group. And there was a significant benefit. And with the initial studies were like, woohoo, it's 90% effective. And out in the wild, it was a little less effective than that, but it still was pretty good. And of course, as soon as that was out there, everybody wanted it. The current recommendation right now, and this is based on some literature that's come out since its release, is to give it to symptomatic adults at high risk for progression to serious disease. We know people over 65 should probably all get it. People over 50 with high-risk conditions should probably all get it. And you could give this to basically any adult. And there's data that just came out a week ago that says it decreases hospitalizations and death even in that group. But remember, we're starting from a low number and we're going down to a lower number in that group. So the reality is that, yes, you could prescribe this across the board, but the sort of more likely somebody's going to do well anyway with it, the less sort of bang you get for your buck for that. The good news is it doesn't have a ton of side effects. It gives you a terrible metallic taste in your mouth. Food tastes awful. It's like having morning mouth for 5 days, but it goes away as soon as you stop taking it. Some people get nausea. Some people get, don't feel so great with it, but that's okay. You can handle that. All that stuff tends to go away. It's not permanent by any stretch. You give it within 5 days of symptom onset, but it's a complicated drug to give. You have to adjust it for renal function. So you have to have an eGFR in people. There's over 60, 30 to 60, 30 or less as far as dosing. 30 or less, it's not recommended. Also with class C or with child Pew C liver disease, you shouldn't be giving it to people either. And the big issue with this is contraindications with other drugs. The ritonavir affects drug levels. And so there's certain drugs you cannot give it with. There's certain drugs that have to be held while you're taking it. And some have to be held and then held even a little longer after you're taking it. It's kind of complicated. I'm sure you all have access to these, but there are forms out there. The Liverpool has a checklist form of all of this. Your pharmacist will know this, but know that there are certain drugs you can't give it with. You have to adjust it for renal dosing, and certain people with liver disease can't get this. It works pretty well though, and I think overall, it's not fabulous. It's not the magic bullet, but it's the best bullet we have at the moment for treating this thing, because that's first line. Second line out there is remdesivir. Now, remdesivir is an infusion. This is something you have to give as an infusion. This is basically 3 days of an infusion, 200 milligrams day 1, 100 milligrams day 2 and 3, indicated in people with high risk for progression to severe disease. Now, I'll tell you, say you're a transplant patient, you can't take something like Paxlovid because it affects the drugs that you have that you're on for immunosuppression. So remdesivir is your best choice here. You have to find out where to get it. Again, you can go to that HHS website, find out where you can get this thing. 7 days of symptom onset, 200 milligrams that first day, 100 milligrams day 2 and 3. And this is basically something that you can give to that group of people that's 7 days of symptom onset. Kids can get it too, smaller dose. So it's okay in kids. Those are first and second choice. Third choice therapy is molnupiravir. Now, molnupiravir, its efficacy, frankly, if it hadn't gotten approved, EUA approved first, it probably wouldn't get approved now, because its efficacy is in the sort of probably teens to maybe 30% efficacy as far as decreasing hospitalization and death. And the big thing about molnupiravir is that it has teratogenicity. Can't use it in pregnancy. Shouldn't use it if you're planning to get pregnant, might get someone pregnant, male or female. No, anybody where conception might happen within 2 or 3 months of taking it, it's not recommended that you take it. Really important. It's 5 days of onset like before. It's 800 milligrams for 5 days. Again, it is really a kind of distant third. So it just isn't a fabulous drug. And then the fourth of this is neutralizing antibodies. Now, the neutralizing antibodies that we used to use before Omicron worked okay. In fact, worked pretty well. They were kind of magic for some people who are high risk. It isn't clear that any neutralizing antibodies work with the current variant soup out there. They're still being used in some cases of high-risk people who are at high risk for getting worse, so transplant patients, myeloma patients, et cetera. But just know that the problem with this is that we're not sure it's going to have any efficacy, and it's kind of just a reaching at straws thing for people who are high risk. So that's an important thing to realize with these particular drugs. So first choice Paxlovid, second choice remdesivir, distant third molnupiravir, and maybe neutralizing antibodies. Evusheld probably doesn't work anymore, still being recommended out there. Really what we're stuck with now is mitigation strategies and vaccination and trying to sort of minimize getting infected. There are some studies that have come out that are a little bit scary about what repeat infections might do to us. One that just came out just this week that looks like it increases the risk of some pretty scary stuff, including short-term, like hospitalization and death by getting a reinfection, no matter who you are, vaccinated or not. Getting infected more than once, not a great idea. And it also seems to still increase the risk of things like diabetes, increase the risk of clotting, strokes, and heart attacks. And long-term, heaven only knows, we don't have a long-term yet to go for, so we're not sure. So there's a lot of things about this virus that we still don't know. It is still messy science. It has kind of pulled the curtain back on how science works and shown that to the world. We haven't been very good at explaining how our science works to people who are not sophisticated enough to understand it. And frankly, you are spending an entire 4 days learning about the science and the studies and all of the quirks and all of the problems with studies. And all of the issues with that. So you are smart people who live in science, who work in medicine. Imagine, sort of the public trying to get any kind of degree of head around this. So COVID is with us. I am not with you because of COVID. It makes my heart break that I can't be there with you. But this is sort of the summary where we are now. We have no idea what's coming down the pike. We've gotten lucky so far that this thing has not evolved to something worse. It could. There could be another virus out there coming down the line that could cause all kinds of trouble. So the key now is to just stay as optimistic as you can, stay as healthy as you can, and do our best to fight disinformation. And I'm sure the rest of the panel there is going to give you all kinds of information on ways to do that. So I'm sorry I can't be with you. I hope this helped with COVID, and I will hopefully see you sometime. Bye.